Thanks, Kevin Jose, for letting me come and for Sages for the honor of giving this talk today. So I'm going to try and figure this out. I think it's going to work. Disclosures, none of these disclosures are going to impact anything I'm going to talk about today. So everybody in the room, I'm sure, has given talks, and my first step is to go onto Google and to type whatever the topic of my talk is, and then to figure out what the latest references are, any new information that's come out. And the first thing I see is that show up on the Google search is, "You perforated my colon, do I have a case?" So this is the reason we're talking about this today, is because not only do you get good scientific literature, but you get a lot of fun social mess that goes along with colonoscopic perforations. But on a more serious note, this is why we're talking about it. The risk of a perforation from colonoscopy is very, very low. Screening colonoscopies, it's about 0.1%. But the complications can be up to 40%, and the death following this complication up to 8%, depending on what study you look at. So let's talk about risk factors, and I'm going to start here by saying that there's a wide variety of literature that exists, and you guys know this on any topic in the field of medicine. Some are great studies, some are not so great studies, so as I'm going through these, I'll try and kind of give you some of the strength of the data behind it as well as just the information. So when we look at risk factors for perforation, increased age is definitely one that correlates. This is also the population who's having the most screening colonoscopies done. So of course the people who are 40 who are not going to have those odds ratios. This can be up to a 3x increase. Some people are saying over the age of 60, others over the age of 75, just kind of depends on which study you're looking at. Female sex also has an increased predisposition. The data on this is weaker, and the real issue here is the multivariate analysis as you look at some of the other factors, and I'll get into those other factors in a moment here, correlate higher in the female population. So the multivariate regression tends to have in some studies this information fall out, in others it stays as a statistical difference. Significant comorbidities, again, one of those things that is not well defined across multiple studies, but everybody seems to say the sicker patients tend to perforate more, which is not really a good thing if you think about the outcomes. Things that we can control, however, and things that are procedure related, severe looping definitely correlated with an increased risk of perforation. As I show you some of the mechanistic slides here in a few minutes, you'll understand the why on that. Poor bowel prep, again, difficulty visualizing the lumen, not knowing what you're doing, using overinsufflation of air in that setting for better visualization leads to a higher pressure, thus perforation risks go up. And prior abdominal surgeries, this is the one that tends to correlate with your female population, and thus becomes a little bit tricky on saying, is it really the female or is it just the fact that the female have had, more abdominal operations and thus more scar and thus more adhesive bands to thus give tension points and thus lead to perforation. When we look at indications for colonoscopy, most common indication that leads to perforation is obstruction, and that makes sense to probably everybody in the room that if you've got a nearly obstructing lesion, you're going to have a higher chance as you're biopsying that area, as you're putting pressure against that area, and there's not much give, and again, on the mechanistic thing, you'll see that illustrated. And then diverticulosis, specifically because you think it's the real lumen, and it's not. It's a false lumen. It's an outpouching. And thus, increased pressure into that area because it's not a full thickness area of the bowel can lead to more complications. The other thing is any intervention, biopsy, polypectomy, dilation, increases your risk for perforation over a screening colonoscopy by approximately twofold. When we look at endoscopists, there's no difference between our GI colleagues and surgeons doing endoscopy. I think that's an important thing to point out. There are some smaller studies that are showing that lower case volume may be correlated with an increased risk. So the study showed that in surgeons specifically who do under 300 cases per year, there's a threefold increased risk for perforation. The catch there is when you correct for other endoscopies, so you're doing a lot of upper endoscopy, you're doing ERCP, you're doing other things that go along with it, all of that information disappears. So if you're comfortable using a scope and you're using a scope commonly, I don't think that data really holds up. The other thing that's been studied but not well shown is training of residents and fellows. So we do think that based on training, there's a difference in the ability to know how much pressure you're applying, not do the overinsufflation of the air. But we haven't been able to show any statistical difference between that, and I think that's because most residents and fellows are well supervised by their attendings in the room, and they're not going to let them get to that point. So, things about interventional aspects. Everybody knows that the 2x increase exists for any intervention, but when we start looking at specific interventions, there are other things that come into play as well. So things that I would have expected, such as number of polyps resected, those large, flat, sessile polyps versus the pedunculated polyps, things that are coming back as a dysplastic pathology as compared to something that's completely benign, were not significant in the risk for perforation. The larger size polyps, typically greater than 1 centimeter in size, were associated with an increased risk. And certain things that we do, such as ESD and EMR, have a much higher perforation risk, but we accept that risk as a trade-off for that minimally invasive approach, and I think that's a very reasonable thing because you get other benefits from that technology. Colon location as well, the right colon, everyone knows, is much thinner in terms of the wall of the intestine, and thus higher risk for perforation at that location if you do an intervention there. So if we talk about the diagnosis of perforations, this is that mechanistic slide, and I think this was a very, very well done description. So again, everything that I've stolen from other papers, citations at the bottom. But you've got direct perforation driving the scope through the sidewall. You've got that bowing that causes the lateral pressure, making that alpha loop most commonly in the sigmoid colon. Perforation at the site of pathology, that's really where the obstructing malignancy comes into play as the etiology. Aggressive air and insufflation, and again, that picture is drawn as a perforation in the sigmoid, but we all know that that's most likely the cecum and not the sigmoid. And then you've got the thermal injury related to your interventional site. As we look at location, again, 50% of our perforations are going to be in the rectosigmoid area. That's the area of tortuosity, increased scarring, the most diverticular disease that you can drive into the false lumen. Following that, 25% in the cecum. So again, your overinsufflation, large pressures, thin walls. Diagnosis of perforation, as is true for anything in surgery, I think you have to have a very low threshold that is your cause and your complication related to your procedure is the first reason that patient's coming back in with a white count of 14,000 and abdominal pain. So good old-fashioned physical exam will often help you with this. You gotta, again, keep that in the back of your mind, even though it is a low possibility. You can do a plain film, it's gonna show some free air, but the CT scans are actually superior, and the reason for that is they show the free fluid as well as the free air. And that free fluid is really gonna help as we get into some of our diagnostic algorithms and treatment, dictate where you're gonna go on this because it's gonna basically correlate with your level of contamination. So if we look at time to diagnosis, 25% or so of our perforations are noted at the time of endoscopy. That's a pretty low number, though, when you start thinking about this big picture, but most of them do present within 3 days. There are case reports of people who are presenting up to 10 weeks after their colonoscopy with delayed things. These are most commonly people who had a small leak, it sealed on their own, they're coming back in with an abscess that's come out later in time. And I think this is the most important point in this talk, and that is not all perforations are the same. So, definitely in there are a wide variety of what is a perforation and when do you have to make an intervention. And there are plenty of scenarios where you get a small hole, you don't get a leakage of air, but yes, it's technically a perforation. Those are managed very, very differently than somebody who comes in with rip-roaring peritonitis and stool all over their abdomen 3 days after a colonoscopy with a 3-centimeter hole blown through their cecum. And I think the difference of that spectrum is why it's not so clear as to exactly what the ideal treatment for perforation is. Many perforations, for example, recognized in the endoscopy at the original time, can be treated without much contamination with a clip placement. However, you're not going to ever try that on that patient who comes in 3 days later with stool all over their belly. So this is the only diagnostic algorithm that I could find out there. It's from the Surgical Treatment of Evidence-Based Problems, and basically works on the diagnosis. So patient comes in, peritoneal signs, head directly to the operating room. This is, again, from 2001. I would argue laparoscopy as compared to laparotomy in many of these scenarios, but since I'm stealing their algorithm, I'm putting it up there as is. However, you've got a hemodynamically stable patient. Start with an x-ray, again, free air, let you know what's going on, no free air, then you head down the CT scan pathway. What I think is interesting in this algorithm, they do point out significant perforation, so I think that's very different, and that kind of goes back to that beautiful spectrum of disease on what gets you a trip to the operating room versus what can be managed conservatively. So as we talk about treatment, our treatments are basically going to correlate with that severity of injury that you saw in all perforations not being the same. So anybody that you're concerned for an ongoing leak needs an intervention. I think that's very different than somebody who's had a microperforation that's sealed, covered, and already sort of autogram patched versus, taking care of itself. That person can be more conservatively managed. Anybody with diffuse peritonitis needs to go to the operating room. You got to get the source control of the spillage that's causing that. But I think, again, along that wide spectrum of presentation, there's a wide spectrum of treatment. When we look at conservative management, 15% of people are going to fail conservative management. It doesn't mean you can't try it at the beginning. If you have somebody, particularly the patient, who's got an elevated white blood cell count, focal peritonitis but not diffuse peritonitis, and somebody that you think can seal off that small thing. That's where your CT scan can help, because again, small amounts of air extraluminally, not so worried, but small amounts of air plus a lot of fluid tends to put me in the less likely going to be conservatively managed, just because that fluid is probably going to seed the abdomen over time. When we look at our outcomes of conservative versus surgical treatment, I think it's a biased study because intention to treat was not where we stayed on this. They all swapped over. So conservative management that needed a surgical intervention, thus the morbidity and mortality goes in the surgical category. But 20% versus 3% for morbidity, mortality 5 versus 3%. But I think there is a selection bias on that because your sicker patients who are coming in a more distressed state to begin with are going directly to the operating room for surgery. So it's not a randomized study. Factors that predict surgical intervention, these are all probably very obvious to you. Poor bowel prep, thus more contamination of the abdomen. Patients who are difficult to examine or communicate with are more likely to get a surgical intervention because you're afraid of missing something. Found that to be one of the more interesting things as we start talking about these systems-based practices and other things that are coming into the way that we're evaluating our outcomes. And again, obvious signs like peritoneal findings, large defects visualized on endoscopy where at immediate perforation, things like that. In terms of the repair that you would do, even if you're heading to the operating room, the size of the defect really dictates the repair. So if you have a small perforation without a thermal injury issue, a primary suture repair with imbrication of that area is a very reasonable thing. If you do have an area of thermal damage and necrosis, you've got to get that area completely removed. And again, a resection of that area with a primary suture closure is still an option. Larger defects, lots of contamination, things like that, need a segmental resection. Don't ever hesitate again here if you do think you need to bring up an ostomy, and I'll kind of go through some of the predisposing factors for that. But you've got to get the source control. You've got to fix the perforation. You don't want to find something delayed that you miss later on by sewing back together thermally injured tissue. Stoma formation, things that are predicting placement of stoma. Primarily on this, what I thought it was important was this early presentation versus delayed presentation. So, the people who come in with peritonitis and fecal contamination all over their abdomen are more likely to get an ostomy. You guys know that. That's true for anything you do, whether it's trauma, whether it's delayed perforation after colonoscopy. Other things, levels of contamination, presence of malignancy also correlated. Time to presentation on the earlier part didn't, but here it did. So just depends on exactly how you're looking at the data and which study you're looking at. Endoscopic options, this is kind of, again, the glory of coming to SAGES and seeing all the cool stuff. Definitely a feasible treatment to repair endoluminal perforations with clips, particularly if they're recognized at the time in the operating room. And again, in the setting of some of our larger interventions, our ESDs, EMRs, this may be something that, again, we're accepting as a reasonable risk and thus being able to make that intervention at the time. So in this study, 93% of patients were able to have their perforation recognized in endoscopy, and of that group, only 7% needed an operation. They were able to be treated with clip placement. When we look at our clinical risk factors, these are things that predict an unfavorable clinical course, and you can kind of see the odds ratios all associated with them. The large perforations, obviously harder to clip, harder to close. Leukocytosis, again, signs of systemic infection, fever. Severe abdominal pain, I think that one's a little bit vague in the concept of full disclosure, but they were able to correlate it. And the other is amount of free air in the peritoneal cavity. And this is the picture from the same paper from surgical endoscopy. You can see that a large perforation such as this, where you could easily drive the scope completely through it, thus resulting in a significant pneumoperitoneum, which authors have described as decompressing with the single laparoscopic 5mm trocar side after clip placement, so a doable thing, are going to respond very, very differently than something like this, where I have to have an arrow added to be able to show you where the microperforation is. But you do still see some pneumoperitoneum, just not the significant volume. So With that, and in conclusion, perforation is rare, it's serious. You got to have it on your radar screen in terms of things that you're thinking about after you perform colonoscopy. There is a very, very wide range of presentations, and thus, because of that wide range, that injury often dictates our treatment. So the algorithmic approach, conservative management, endoscopic clipping, heading to surgery and going directly for a stoma is going to be dictated by how that patient presents and what kind of a defect you're looking at. And I think the most important as well, prevention through good technique is really where we need to be going. Try and lower this number as much as we can. So I'll close.